Okay, it's now 7 o'clock, so I'm going to start the recording, and I know a lot more people might be coming in the next few minutes, but we just want to get started. So thank you all so much for coming to the first official educational Student Advisory Board event of the year, which is entitled The Color of Care, Rethinking the Textbook Case. So before we get started, we just wanted to give kind of a rundown on what IPE is, what the Student Advisory Board is, what we do, and ways to get involved. So as just a very brief introduction to IPE, we really just want to promote any IPE efforts amongst the 10 programs on campus, which are listed here: medical, dental, PT, OT, nursing, public health, nutrition, social work, genetic counseling, and pastoral care. So you can see here some of the photos of our past events in person. They've been a really great time. You've gotten to meet a lot of people from different fields, learn what those fields do, and hopefully we can start emulating that virtually. So these are our objectives. Definitely don't need to read this, but basically we just really want people to understand more about where they fit in on the interprofessional team. So again, some past events that we've had. This is a photo of some previous IPE seminars. Here's our IPE kickoff in 2019. This was the gun violence case study hosted by Mailman last year. This is our executive board last year, and this was the dental Valentine event with the oral mind-body connection. So basically, the Student Advisory Board hosts one event per month, and every month a different school will take charge to work within the Student Advisory Board to make the event happen. So some of the past events that we've done a DGMA event jointly where we've taught some different Spanish languages, we've taught some different cultural competencies. Nursing hosted an escape the room where students worked in interprofessional teams to get past every little room and get on to the next one. So, oh, this person has the symptoms of X, Y, and Z. What's their differential diagnosis? OT and PT have done some great rotations. We've learned how to put people on stretchers, do things like that. So it's been really great. The Student Advisory Board Executive Committee this year are the 5 of us. Although interest form has closed for the Student Advisory Board, we of course will always welcome new people. So if you are interested, just email me a short statement of intent, and my uni is down here. It's MNS 2147. So different schools have different requirements for what constitutes an IPE event, and it really kind of depends. So this is the official rubric, but if you really want to know, you should reach out to your IPE contacts, which are listed here, to see what counts, what your requirements are, because every school honestly is different. Then finally, we have ECUIMC, which if you're a first year, you might be going through this right now. If you're a second year, you probably went through this last year. Basically, it's a mandatory virtual introduction to IPE. You're assigned 1 week for the entire semester to work in interprofessional teams on an asynchronous Canvas course to treat a patient with multidisciplinary considerations. So you learn more about your other group. You're only paired with, I think, 10 other students, so you really get to know them and learn more about what every profession does. So those are the official competencies. And then finally, we have IPE Day, which is a day on the campus where all classes stop, all clinics stop, everything stops. And you just have the opportunity to attend interprofessional workshops and lectures. You meet students in different disciplines and learn about what they do, learn other people. And this year it will be virtual and it will take place on March 30th. So the entire day should be blocked out from your calendars already. And as it's virtual, we wanted to be respectful to students in different time zones. So you'll be able to kind of pick and choose throughout the day what interests you, what works in your time zone, and choose from there. So then finally, before we get into the event, just some upcoming events. If you are interested in getting involved with the Student Advisory Board, we meet the last Thursday of every month at 7 p.m. And some of the events that we're doing / done so far, we had our kickoff to IPE, we had a trivia game, we have tonight's event. the School of Nursing is hosting a naloxone virtual training, and you can see the dates listed here. So there's one this week, one on the 19th of November, and one in December. And you can sign up online, and I believe that the Center for Student Wellness sent out that link earlier today. And then other events this semester that we wanted to get to were just some ethics in the COVID era, the rise of telehealth in dealing with IPE, student debt, how to refinance, and how to deal with ethics. Then we also have Columbia Commons events this semester, which are more so facilitated by the faculty division of the Student Advisory Board, which include the gun violence case study and geriatric shared classroom. And those dates we have at the end of the presentation, but have been announced. So again, if you'd like to get involved, feel free to email me. We'd love to have you on board. So getting started with today's event, these were the objectives that we had posted. Basically, we want to have everyone leave at the end of the event with a better representation of biases in medicine. So we started off with a short little matching game. I'm gonna stop my share so I can post this in the chat. This is very low key. I'm going to separate everyone into breakout rooms. Just work for the next about 5 minutes or so on this Google form. Speak about it, see if you can match each dermatologic condition to the skin type, and then we will come back in just a little bit. Okay, so I think we are all back. This was basically just an exercise in awareness to let you know kind of how different things show up on different skin types. So disclaimer, this is all from Brown Skin Matters on Instagram. Great account. If you are interested, definitely recommend you follow. And I'm going to briefly go through the answers now before we have Dr. Hansen come on. So this was shingles. This was tinea versicolor. This was pityriasis rosea, erythema multiforme, and Kawasaki disease. So any further reading, I'm now posting a link in the chat of a great New York Times article, which I enjoyed reading. And if you're looking for any extra information on this topic, I highly recommend you read this article. So now I'm going to turn it over to Sarah, who is going to introduce our guest speaker for tonight.
Great, thanks, Michelle. So I'd like to introduce to everyone Dr. Letitia Hansen. So Dr. Letitia Hansen is an assistant professor of nursing and director of diversity programming at the School of Nursing. She received her undergrad degree from SUNY Stony Brook in biochem and psychology. She received her master's degree and doctorate degree from Columbia University School of Nursing. She currently practices as a psych mental health NP working with children and adolescent populations and teaches psych and mental health nursing for the MDE program and fundamentals for the psych mental health NP program. So let's all welcome Dr. Letitia Hansen.
Hi, everyone.
Hi.
I was just in one of the breakout groups, and I'll tell you, I'm glad that I'm not teaching in regard to integumentary system. So it's a pleasure to be here. It's a pleasure to see some old faces in the crowd. Thank you for inviting me tonight. I'm going to do the screen share to pull up the documents. Let's see. Okay. And we're going to be talking about bias in psychiatry. So some of the objectives we'll look at is understanding bias, identifying the different forms of discrimination, understanding the impact of culture, and also the importance of cultural competence. Before I start, I should tell you that I have more than the time prepared in terms of the notes and the material. So I'm going to go pretty quickly just to keep in time with the amount of space that we have. So we're looking at mental illness versus serious illness. Mental illness being any mental health condition, bipolar disorder, schizophrenia, and depression, all categorized as serious mental illness in regard to the fact that they cause more functional impairment. General mental illness can be anxiety, it can be ADHD. Anosognosia is the lack of insight, and we'll see that over 50% of patients that have schizophrenia and 40% of patients that have bipolar disorder may often have trouble finding treatment because they don't recognize that they have a disorder or that there's something that they need assistance with. This has led to untreated people, which has led to encounters with law enforcement. Um, the next thing is just talking about prevalence. With mental illness, noticing that there's a disparity to care. This could be because of, and this is with any mental illness here, this could be that there's this disparity because of stigma. It could also be because of lack of access. And these are some of the disparities that we will be addressing tonight. And this is with any mental illness in terms of services that were received, courtesy of SAMHSA. And once again, we can see that the received services were greater amongst our white patients. With serious mental illness, the prevalence we see is greater in 2 or more nationalities and also in our white patients. And once again, in terms of services, we can see that there's more of a prevalence of being able to access services if you were white. The next thing we'll look at are some definitions. So in regard to ethnicity and race, that they are socially constructed categories, and with xenophobia, that prejudice or dislike of people from different cultures. Regarding racism, thinking about the aspects of racism where structural racism, looking at the places and spaces in which patients have been discriminated against, or even people in general. For example, like the immigration policy is one of those large overseeing areas. Institutional racism could be schools, workplaces, the criminal justice system, and then also individual racism. So the different elements of racism. Microaggressions, we're looking at everyday insults. It could be something that's unconscious or conscious, but prejudicial comments. And what we are really doing at the School of Nursing and also within Columbia University, and I think as a whole, is trying to be anti-racist. So trying to eliminate racism through change. Implicit bias is noticing unconscious attitudes that we have towards race, towards gender, towards sexuality. So this is one example here with unconscious bias. Unconscious bias is something that we all have. And what I'd like you to do is take a look here at this picture, and let's think about the small train that we see in the front and the train that we see in the back. And what do you think in terms of the size? Do you think that they're the same size, or that one is larger than the other, or one is smaller than the other? Let's see, I have a couple of, okay, one is smaller. Okay, it's an illusion, they're the same. Okay, maybe the differential perspective, the same. Okay, so we have some pretty good comments. So the idea behind implicit bias and unconscious bias is that our mind is always thinking. Our mind is always trying to figure out if there's any harm. This is what helps for survival. If you're walking down the block and you're seeing, is this a cat or is it a cougar? So we're processing this information. So if I go to the next slide, you can see that they're actually the same size. So we were looking at the tracks, we were looking at some outstanding information, and that was then interpreted to mean that they were different sizes. Here's another one. Let's see, could you find the 3 daughters? Okay, so some people have found 2. Okay, so we all see the main feature here. But we actually had to look and see that there's one here. She's upside down. There's one here in the beard, and then there's another one here in his hair. So those are the three people there. Whoops. So in regard to healthcare disparities, when health outcome is greater or lesser for one population, racism can cause some of these inequalities, and morbidity or mortality are two of the things that are sometimes happening because of these healthcare disparities. And they're often impacted by race, by sex, by sexual identity, and age, disability, socioeconomic status. So these are a number of ways where someone may show healthcare disparities. And geographic location is one of the others. And these are part of the social determinants of health. So COVID was one of the biggest things that made racism and made social determinants of health more aware for people. For example, some of my patients were depending on the school system for food. So they didn't have adequate access to food. Over 11 million children in the United States don't have adequate food access. Education is another social determinant of health, where in certain income, in certain brackets, children don't have the same educational so certain educational elements available to them. So for example, they may not have access to the internet or to computers right now. Within the social and the community aspect, it could be the resources in the community with economic, job and income debt, or unemployment or medical bills. And then within healthcare, recognizing that coverage, accessibility to services, quality can also be affected. So thinking about equity versus the disparities, and these are the definitions from Healthy People 2020, they're going to be explained with a picture here. And what I'd like everyone to do is, I'm sure we have all seen this picture of equity versus equality, the last one, liberation or justice, in some format or another. But why might this help and why might this hinder our guide and our benefit to try to reduce racism? What problems do you see with this picture? Okay, starting point and end point. Okay, it doesn't take individual needs into consideration. And what's one other reason that we're all here today? So the main things that they're showing you are that with equality, you're given all the same resources. With equity, it's giving resources to those who need the most. The reality is that oftentimes the ones who don't need it have the most resources. And then with liberation is taking the fence away. So taking away those systemic racism elements. But one thing that this picture does that makes it challenging is that it's saying that there's something wrong with the actual person. So either they're not tall enough or there's something that they need to change in order to be able to have better access to care. So the individual needs, yes. So thinking about the populations that we'll be talking about, one of the main populations, African Americans, because of what's going on right now in the community and because of so much unrest after there have been the death of African Americans, we're noticing that this is what the literature is pointing out, in addition to what patients have reported, that they have been stereotyped to be. Some of the African American women report the angry Black woman. African American males bring up that they're perceived as being the strong Black male. Pain management is often not what it should be because they're coming in asking for a medication and they're being stereotyped or judged as if they have either a substance use disorder or that there's something in drug seeking about the pain that they're required, or that they're just not having the amount of pain that they're reporting, so not really adequately diagnosing them. Sexuality, patients have reported that they feel, providers feel as if they're already sexually active, or that they may have something sexual active in their history. So like for example, one of the 60-year-old women that I work with, she had reported that she had come back with an HPV positive test. She had been married over 40 years. Her husband had cancer. And rather than talk to her about what HPV was, her provider said, it's a sexually transmitted disease. And this woman then felt isolated, and she felt, how could this happen if my husband has cancer, if I've never been with anybody else? So putting this blame for sexuality. The other thing is limited cultural knowledge from different providers. The next group is with, well, continuing with African Americans. In the 1960s with schizophrenia was a diagnosis that was put on people that were rioting or protesting. I want to point out right now that being part of a protest is very different than the people that are part of the riot. They're political unrest. However, providers were diagnosing schizophrenia as a form of saying that these people that presented were angry and hostile. And the diagnosis of severe mental illness in patients that don't have providers of the same ethnicity has led to heavier medication. This is from one of the voices of a Latina female patient that went to the emergency room and was asked if she was having sex by a male doctor, and felt like they had made this assumption, and that they asked her, it made her feel awkward, and she's telling you no, and that they felt like she thought that they were telling her that she was lying. So this is some of what the patients have put. This is from one of the literature studies. So feeling as if they're being blamed, challenges that come up for undocumented patients, challenges with language, feeling judged, worried about the cost of services, feeling as if they are excluded from their healthcare decisions. Other populations include the Asian population. This here is specific to some of the comments that I've heard now around COVID from my patients, that they felt that there was discrimination against them, specifically after hurtful comments like COVID being from China, and the language that was used by other people. So this trickled down from society and from the community, even going for a test, being told, have you traveled outside of the United States, but only specifically to patients that were Asian. So they felt that there was bias that was being done when they went to see providers. The other study looks at South Asian patients, specifically from South Asia, India, Bangladesh, and Pakistan. And this also brings up many of the migration, acculturation, gender disparities that have come up. Female immigrants and self-harm and mental illness were one of the things that they found, that there was a disparity for healthcare. Stigma and somatization. The next was the cultural differences, where in the United States, individualism, independence, and with the South Asian values, it was more for family cohesion. So perhaps we need to meet patients where they are and provide cultural competent care that is more in alignment with their culture. In regard to other populations that are outside of race, there's the LGBTQ patients that have reported they would like us to use gender pronouns, the gender unicorn, explaining gender identity, gender expression, and emotional attraction. The next one would go into populations of other needs, like patients with mental illness in and of themselves have had stigma, patients believing that mental illness is a weakness, women and women's rights, and also patients that are overweight that have felt challenged by their providers, pointing out or not being sensitive to issues. Phenotype discrimination, when we look at our mental health, discrimination based on characteristics like skin color and hair texture. And this can be seen in multiple areas, not just the United States, and it affects school, it affects housing, employment. The next one are the vulnerable populations that include victims of domestic violence and abuse, patients that have special needs, undocumented patients, children and adolescents, foster care, homeless patients, including with reducing racial bias and improving care. We want to talk about quality services. We want to talk about providing training for the provider so that we can reduce bias, and then awareness that making quick decisions in distress or in duress can lead to these implicit racial bias comments. Improving care is going to require trust. So thinking about what we can do to help the patient, meeting the patient where they're at, having a voice and having the patient feel listened to, thinking about body language. One important quote that I have down here from Maya Angelou is that at the end of the day, the patient that we're working with won't remember what we did or said, but they will remember how we made them feel. So it's really important for us to try to make patients feel as comfortable as possible. Improving assessment. So tests have been pejorative and pathologizing, and emotional experience has been a deterrent for patients seeking care. Trauma-informed care would be another consideration, and taking into consideration religion and culture. So diagnosis, we need to make sure is specific to the symptoms, but also taking into consideration culture and religion, thinking about the biopsychosocial model to drive either medication management, therapy, and holistic care and cultural interventions, spirituality, volunteers, tailoring treatment to culture. So even having a volunteer or another staff member from the person's culture can help the person feel more at home. Using community resources, the cultural settings themselves, like hospitals, which can feel scary. If we have art on our walls or we have different cultural elements that we include in the session. And then I just wanted to talk a little bit about telemedicine. With telemedicine, I've been using telemedicine with my patients. It can be something that is helpful, but however, there are a number of elements that culture brings in, and also the social determinants of health, like not having the equipment, not having the proper internet, the knowledge of how to use the equipment, even self-esteem, just having to watch yourself for a half an hour med visit and not feeling that you feel comfortable with how you look. And then the cultural implications of not being able to really see a person, have the eye contact with the person. Perhaps my camera is not in the same line of sight. So those can lead to people feeling uncomfortable about the visit. And then in regard to future, so looking towards the future, being able to work together collaboratively with multiple disciplines in order to bring together more diverse and more culturally competent care. So Michael Jordan has his quote. The next one, we have one piece of log that creates a small fire, adequately warms you, and just a few more pieces to blast an immense bonfire large enough to warm up your entire circle of friends. Needless to say that individuality counts by teamwork and dynamics. With James Baldwin, that not everything that is faced can be changed, but nothing can be changed until it is faced. And then the last one, it is not our differences that divide us, but our inability to recognize and accept and celebrate those differences. So being able to value each other for the cultural changes and the culture that we bring to the relationship. Sorry to rush through it, but so I'll stop the screen share.
Thank you so much, Dr. Hansen. I'm posting right now some questions in the chat that we received before this event. We'll just take a few, but I think the first one is, how can we as providers be more compassionate to our patients of color?
I think the first way is by meeting patients where they are, by being the person that the person of color feels comfortable talking to. So allowing the space for this interaction. I think in today's society, everything is so rushed. We don't take the time to really get to know the people that we're treating as providers. And that's really important because, for example, at my clinic, I could tell you how many people have had stage 1 cancer and have not gone to their primary care provider because they didn't have rapport, and they've actually died from it when we could have treated this. but they did not feel comfortable. How many patients of color don't get mammograms? Because they don't feel comfortable. So I feel like having a space where patients can talk to us and having a space where patients feel comfortable can really go a long way.
Thank you. Another one that we were asked is, why aren't we already using photos of different colored skin, black, brown, yellow, etc.? And how can we transition events like this into being integrated into our curriculum across our 10 schools?
I think that it's been challenging for patients of color to want to be a part of studies, and that research has been limited. Like even, for example, with vaccines and with medication, patients of color, because of the history and how we have been treated, they're afraid. They don't trust the system. It's like, for example, now, if they told us that they had a vaccine for COVID, how many of us would go and sign up? We would be afraid. There's been so many people of color that have passed away because they went to the provider and they went to get help and they were following what was said on the news, not wearing masks in the beginning, and they got sick and family members got sick. So there's an element of not having trust. And it's because of society, it's because of Tuskegee, it's because of a number of studies where Black people have been experimented on. So we need to work to build that trust and have more studies so that we can have more voices and we can have more pictures of people of color. And I think also asking, I think as students, what you're doing really helps us as faculty to understand that we need to do more and we need to add into pedagogy things where your experience, what you'll be working with so that you're prepared, because the textbooks often don't have it. So we're really at the front lines trying to go out and find the information that we need to make you as diverse as possible.
Thank you. And then if anyone has any further questions, feel free to put your name in the chat and you can unmute yourself or type your question. The last question was, do you know of any resources and or a database to find BIPOC therapists for referrals to support clients and patients for this provider preference? And then Alden posted the shrink space with therapists of color, but if you had any other ideas.
That's a really good question because access to care has been so challenging. Like the average wait for an adult psychiatric evaluation can be a month, up to 6 months at times. So even just getting the access to care, most of the time people have been using the emergency department because they don't have the access. But I can definitely look up a couple of resources and send them out. I know because of COVID, we're doing more in terms of finding resources for patients of color and bringing those resources to people. In the past, it's been expensive. And I think that people are now trying to do more in terms of providers giving either access to patients of color or having resources where they're providing free services. For the students, I think utilizing student health and it's a really good benefit to have. And also to reach out to your other like administration and to your professors. We're all here as resources. So I feel that if you do feel that you're struggling or you need to talk with the Columbia community, utilizing each other, those patients and the people from the community, I think we need to do more for reaching them. And I think that there are a few organizations that have started having more diverse, either reduced scale or less pay for therapy, because therapy could be upwards of $100 to $200 for an hour. So for patients that can't afford to pay, this has led to less care for them. But I will get back to you, Michelle.
And then just to finally close it out, and thank you, Dr. A, for posting that helpful link as well. Rebecca posted about the book Mind the Gap, to have the Black skin references next to the white ones. And I personally have not heard of this book, but this is something that sounds very intriguing. And as you mentioned, Rebecca, we should advocate for in our classes. Yeah. So thank you so much, Dr. Hansen, for being here. And thank you so much, everyone, for all the questions that you had.
Thank you.
And with this, I'm now going to turn it back over to Zenas, and he's, I'm so sorry, going to lead a very short discussion before we wrap up.
So, hi. So I think we have two different cases for you all to work on in your breakout rooms. So if you go to so the first one is going to be your patient comes in with a large rash, and we want you all to just write down what are your first thoughts when you think of someone that comes with a rash? What do you see? And then after that, you're going to think about it again, but this time you're going to imagine, if you didn't already, that your patient had darker skin. Now what would you see? And try to discuss it amongst your group. Yep. And then hypoxia. If people don't know what hypoxia is, it's basically low oxygen in the body. So imagine someone having trouble breathing. What would you see? And then again, after you write down what you think about that, you're going to do the same thing, except with someone with a person of color. And you're going to discuss it again with your group. Yep. So yeah, just join your breakout.
Okay, welcome back, everyone. Just to finally wrap up the event for the night, we're just wanting to go through a few discussion questions based upon what you talked about in your breakout room. So for the first one, I'm going to hand it over to Hedda.
Sure. So after talking in your groups, how did your definition of rash change after describing it in a darker skinned person? Feel free to put it in the chat. From red to warm. Yeah, another person said a rash doesn't equal redness necessarily. Yeah, these are all really good answers. More of a focus on texture and temperature and sensations. Everything, it's more patient focused. How rashes will typically be raised and itchy. Irritated skin. Yeah, I think all of these begin to consider a more patient-centered approach to care, and I think that's really important to think about, especially when we're talking about equity in healthcare and looking at color and how different conditions might appear on different skin tones. I'll pass it on to question number 2. I think Brooke.
Yeah. Okay, so similar to the first one, how did your definition of hypoxia change after describing it in a darker skinned person? Feel free to put it in the chat. I can read it out, or if anyone wants to unmute themselves and discuss. Not using blue to describe lips and fingernails. Yeah. Oh, this is good. So the bluish tinge may not be present in people of color. Instead, check mucosa. Similar with the oral mucosa is a white-gray color, or using a pulse oximeter and observing patient for nasal flaring, tripod, and shortness of breath.
Yeah, those sound really good. Thanks everyone for contributing.
Okay, so should I do the third question? So many classes describe symptoms as redness, tenderness, and swelling. How has your description of those symptoms changed? Yeah, I think for me at least, I think instead of redness, I would think of like maybe hyperpigmentation or hypopigmentation. You know, looking more at the texture of something instead of seeing if it's red and raised. Sometimes you just have to feel it.
Yeah, and I also agree with people saying, you know, trust what the patient's saying. At the end of the day, they know their body the best. So listen to what they're saying if they say that something's not right. I also see in the chat some discoloration or texture or symptoms, kind of using those to define this. So yeah, I think those are all great questions to ask and great things to replace the redness, tenderness, and swelling. So we're heading up to 8 o'clock. Basically, again, just thank you all so much for coming tonight. I'm posting now a survey in the chat, which will also be emailed to you guys. Follow us on our brand new Instagram to stay up to date. It's at Columbia IPE. And again, the Student Advisory Board meetings are the last Thursday of each month at 7 p.m. So this month it'll be on the 29th. For our November Student Advisory Board event, we will be having a different speaker and a different topic. And then the upcoming Columbia Commons events that I spoke about earlier, the geriatric case and the mailman gun violence case, they are at the dates shown below. So again, thank you so much for coming. Thank you, Marie, I think, for posting Mind the Gap in the chat. I will definitely be downloading this. And yeah, if you have any questions, please reach out. Please let us know if you have any questions. So thanks again for joining. Have a great rest of your week.